for another episode of Coffee with Coker. My name is Mark Reibold, and I'm the host. And this episode today, we have a few guests, and we're doing a recap of a recent presentation that was given at AHLA Transactions Conference in early May. So we are joined by Justin Chamblee, who's the Senior Vice President here at Coker. And we also have his two co-speakers that presented with him. The first is Tom Donohoe, who is an attorney, in-house counsel now at SCL Health out in Colorado, and Priya Bathija, who is actually from the American Hospital Association. And Priya, Tom, and Justin gave a presentation that was titled Exploring New Frontiers, Evolving Alignment Options Between Health Systems and Rural Hospitals. So this was one of those presentations that got a lot of feedback, positive feedback, and a lot of interest because, you know, this is something that applies to a lot of the folks that were at that specific conference, but it's also gotten a good bit of follow up in that it's something that is very applicable to a lot of our audience. So whether you're on the hospital side, and whether you're on, large multi-facility health system in an urban area, or specifically in this case, talking a lot about the unique characteristics of or application of some of these new strategies for rural hospitals, which is applies to a lot of you out there, but it also applies to physician practices as well, as you are in rural health environments. And you're thinking about engagement and alignment scenarios with hospitals. These are very relevant. So it was very interesting. They talked about some of the newer models, or even kind of the evolving characteristics of some of the current or more traditional models. And, that's what we're seeing. This stuff is continuously changing and evolving. And so they did a great job presenting this. And we had a great discussion just recapping some of the key takeaways and kind of looking into the future of what they think could happen. I do want to say real quick, we wanted to specify that, this was a presentation or material on a presentation that was previously given at the conference. And so this does nothing that's said in here at all is not constituted as legal advice, is not intended to be legal counsel in any way. This is just discussion and observation. So we just want to make sure that disclaimer is out there. And as always, we invite you to provide feedback. You can submit feedback on topics you'd like us to cover in future episodes, or questions about anything we talked about in the past. You can reach us at feedback@cokergroup.com, or contact us directly on the website, cokergroup.com. And then finally, you can listen to this and all of our previous episodes at coffeewithcoker.com. And with that, I hope you enjoy this episode talking with Priya, Tom, and Justin. Jumping into the discussion here, we're talking about exploring new frontiers, and specifically we're talking about evolving alignment options between health systems and rural hospitals. And as we mentioned in the intro, we have Priya Bathija, Tom Donohoe, and Justin Chamblee. They recently had this panel presentation at the American Health Employers Association Transactions Conference that took place in May in Nashville. It was a hot topic. A lot of people were interested in this topic and already have received a lot of positive feedback. So we wanted to just kind of recap it real quick. And so Priya, Tom, and Justin, I'll just turn it over to you guys. Maybe let's just start with, what were the key takeaways that you guys wanted to communicate with this presentation, some of the key observations, and anything that came up you thought was, particularly relevant to the overall discussion? Maybe Justin, if you want to kick us off.
Yeah, Mark, great question. I think the three key things that we wanted to focus on were, first and foremost, why rural hospitals are struggling or looking at alignment options, and then really diving into some of the models, both traditional foundational models that are being applied, but also some more of the novel or unique ways that rural hospitals can align with other partners. And then finally, by nature of it being a Health Lawyers Association conference, we really wanted to dive into some of the legal dynamics that play into some of those alignment options.
That makes sense. And so why is rural health? I mean, let's start big picture, I guess, or set the stage a little bit. Why rural health? Why rural hospitals? I mean, what's the relevancy there?
Sure. I think rural hospitals face a lot of challenges and really serve a unique population. So right now, more than 59 million individuals, or approximately 20% of the U.S. population, lives in rural areas. And the conditions of those individuals, they tend to be more disadvantaged than those that live in urban and suburban areas. Their residents tend to be older, sicker, and poorer than the national averages. So they have a really challenging patient mix. And then they also have a challenging payer mix in terms of the reimbursement rates that they're getting from their biggest providers, which are Medicare and Medicaid. So they face some challenges there. They also, face other challenges in terms of low patient volume, shortage in workforce, and a variety of other things that we have actually highlighted in an AHA rural report that we released earlier this year. But the result of all of those challenges is that rural hospitals right now need to look at other options. More than 40% of them have a negative hospital margin, and we're seeing them look at a range of options. So some have elected to merge with larger health systems or engage in other types of affiliations or partnerships. Others have chosen to modify service line offerings in order to stay open. So in some cases, that means they've looked at closing certain service lines or converting their hospitals into outpatient facilities or urgent care centers. And still others that can't make either of those solutions work have to close. And we're seeing a lot more closures now than we have in the past. And specifically, 95 rural hospitals closed since 2010. So this conversation is particularly important right now because of the situations that rural hospitals are facing and the difficult decisions they are causing them to have to make.
That's really helpful, Priya. And I want to make sure we mention your role as far as the AHA. You guys presented in your slides what I thought was some really interesting data from and conclusions that you just talked through, a number of them from a report that you guys did. And so I would encourage our listeners to check that out. And again, there's a lot more kind of data points and probably goes further into the weeds, I'm sure, even beyond that as well.
Yeah, it really sets the stage as to the challenges that rural hospitals are facing right now.
Sure. What are your thoughts as far as, not to jump ahead of ourselves, and I don't know that you guys spent time talking about this in the presentation itself, but any thoughts as far as looking to the future and as far as how those different variables could end up changing or continuing to impact these organizations, or what some of the dynamics will be as we think about maybe the next few years?
Yeah, I mean, I think we're going to see a lot more hospitals look at different models. And one of the primary reasons for that is that many of the challenges that we highlighted in our AHA rural report aren't going to go away. So, for example, we break down the challenges into 3 groups: persistent, recent, and emergent. And while new ones keep popping up, the persistent and recent changes we have seen consistently year over year. And while we continue to advocate for solutions that could help to decrease some of those challenges, I don't think that they're going to go away. And as we continue to change and evolve how we deliver healthcare, we're going to have to start having different conversations about the best way to do that. And in many cases, that will involve having conversations about who are the right partners to partner with to ensure that we are utilizing community resources in the best way possible. So I think you will see more dialogue around new alignment options. You'll see hospitals create these alignments with new partners that they might not have considered before. So we'll see a lot of change on the horizon.
Sure. Let's talk about the affiliation models that as we're talking about evolving models. I guess another thing we could set the stage for is, what are some of the models we're looking at? And Justin and Tom, maybe if you guys want to chime in, what are we looking at? And then what do we have to look forward to as far as maybe how some of these models are evolving?
One of the things that we have seen occur and we will continue to see is some of the what I'll call foundational alignment models, and that involves management agreements, joint ventures, acquisitions or leases. These have been extremely prominent in the past, will continue in the future. and they have their place. And one of the things that we really tried to highlight in our presentation is there's ways that rural health can look to align outside of these models where they are sacrificing a lot of control or ownership. And some of the things that we looked at are, first and foremost, having rural health look at the services that they're providing and recalibrating those to make sure that they're meeting the needs of their community. And one of the key topics that we focused on is this idea of a hub and spoke model where you're really focusing on providing the high acuity services at hub hospitals and let rural hospitals truly do what they can do best, which is providing more of those spoke services in terms of population health management, preventative care, things akin to that. And when we truly focus on a hub and spoke system, it allows us to utilize all of our resources appropriately. We talked in the presentation about some of the challenges and the benefits of this model. I don't think we'll get into too many of those right now, but needless to say, the whole idea of a hub and spoke system is greater efficiency and quality by nature of concentrating those higher acuity services at the main facilities, better leveraging resources in the rural markets to provide the care that can be best provided there. But then the challenges oftentimes involve just the distance that can come into play, as well as the lack of autonomy and the required reliance on the various partners for that system to truly be successful. We talked about a few other models, and I'll highlight two of them and then throw it over to Tom, and he can elaborate on others. But we talked about telehealth and how telehealth is allowing rural health to tap into the resources of larger health systems and provide that higher level of care in the rural setting. We talked about the use of electronic medical record donations as well, and how so much of healthcare today is focusing on access to medical records, having strong technology platforms, and through some of the programs that exist right now from a governmental standpoint, there are opportunities for larger health systems to allow rural hospitals, rural practices to tap into their technology resources and have access to systems that they would otherwise not have access to, which really then allows some of these other programs to thrive, meaning the hub and spoke system, telehealth, things into that. And really what we like about these models is it doesn't necessarily require a full-scale effort or a loss of autonomy or control. It's more so, seeing a need or a gap and working to fill those with the other health systems that you can affiliate with around you. So, Tom, maybe you can just elaborate on some of the other models that are out there that we touched on.
Yeah, and I'll even piggyback on a point, Justin, that you just made in terms of what I would call incremental alignment. I think when health systems initially wanted to expand their network by affiliating with rural hospitals and rural hospitals come into those systems, you did see more of those foundational models. And in my experience, both in private practice and as in-house counsel, I think you saw health systems come with the mentality, listen, we will affiliate with you as long as we can have an optimal level of control for the health system. And in a lot of cases that worked, and you could use a management agreement, a joint venture, some sort of acquisition or lease strategy to ultimately facilitate that control type of relationship. But as Justin explained some of the hub and spoke model, it's important to note, I think the mentality has changed as health systems have grown and rural hospitals have affiliated based on lessons learned by both, where the health system is more geared towards looking at the needs of the community now and being a little bit more sensitive to the rural hospital's need to kind of incrementally develop a relationship with that health system before it may mature into a larger scale transaction. And I think that helps the smaller community as well acclimate or become familiar with the health system that may be providing services so that when maybe one of these larger transactions occurs, it's less disruptive. So as far as, Justin speaking to the telehealth model and to the EMR donation model, again, those are some incremental tools where you can allow that relationship to develop and see if they can partner on those types of services. And if those are successful, go to the next level. A couple of other tools in that toolkit as far as incremental alignment go, we have, when I say we, it's more in terms of the health law industry as a whole have seen the use of what I would characterize as a joint venture service line utilized where a community might have a need for a service that it doesn't have, nor will it really make sense for it to develop the capabilities on its own to develop. But it could be oncology, it could be cardiovascular, or something else where it might make sense given the patient population and the needs of that community to have a cath lab there, or maybe have an infusion suite or a linear accelerator to provide radiation treatment. But what we've seen is the rural hospitals come to the large systems and say, "Hey, will you partner with us on a joint venture basis to develop that service in the community?" And so the large system will bring some of that expertise. The rural hospital will jointly develop it with them, and again, the service will ultimately be available for that community, and that can typically be structured as a separate joint venture entity or through a contractual relationship as well. And there's a fair amount of nuance that goes into those, but you will see some different iterations of it in terms of how they jointly partner on that type of service. And then I think another one worth mentioning, or it's a pretty simple and straightforward model, but a relatively effective one, and that's in the form of a kind of a visiting specialist arrangement. You might have a rural hospital that is that has a general surgeon on staff that has primary care, but it really lacks specialists to come to the community to see patients, and those patients are having to travel miles for pre-operative, post-operative, or other types of visits. And if a rural hospital has the specialists from a larger system come out and provide services either through a lease arrangement where the large health system is leasing space and providing services in that space, or it's entering into a professional services agreement with the smaller hospital, whereby the smaller hospital is purchasing those services, but it gets that visiting specialist in that community to see those patients so that they don't have to travel so far. And it introduces the smaller community to the resources of the larger health system, and it's a win-win in the sense that the smaller hospital gets to retain that service in the community, and the community members don't have to travel so much. So I think those are a couple of additional tools beyond what Justin kind of spoke to that again allow for that incremental alignment and really serve that philosophy of putting the community first and bringing those resources to the community as opposed to just outsourcing them all to or making them go to the larger system facility, which may be closer or maybe of some distance.
Yeah, one other thing, maybe Priya, you can touch on real fast as we talk about the incremental alignment idea. In our presentation, you just highlighted how the board of some of these rural hospitals plays a role in the alignment dynamics. And so maybe just elaborate a little bit on that because I thought it was a good point as to how these alignment models can truly function and the incremental alignment concept can be beneficial in that regard.
Yeah, absolutely. And, when we were talking in Nashville, Tom made the point that, a lot of these hospitals are not only subject to federal laws and state laws, but they also have a lot of local regulations that they're dealing with. And one of the biggest ones that we see in our conversations with members is the fact that they are county-run hospitals and they have county-appointed boards. So in a lot of cases, they have trustees that are being appointed by another entity that don't have healthcare experience or really the understanding and knowledge of how hospitals work and some of the changing dynamics in the healthcare environment. In addition, a lot of times they don't have term limits. So they have the same board members who continually serve on boards year in and year out. And so they don't necessarily understand the need for some of these affiliations for the rural hospitals. A lot of times they don't want to consider these options because they don't want it to happen on their watch. So I think as we as a field move forward and as rural hospitals move forward, board education is going to be critical, and not only in educating hospitals on the changing landscape, the challenges that are coming at rural hospitals, but also sharing what other hospitals are doing to address these challenges and as we've discussed in this conversation, really the full array of what alignment could mean. It doesn't necessarily have to be, merging completely with another entity. It could be developing service line relationships, as you talked about, or any of the models you talked about. And having those conversations and changing the discussion that happens in the boardroom, I think, is going to be a key step for many of these rural hospitals going forward.
Yeah, that's a really good point, because I know we work with a lot of hospital clients, and particularly rural hospitals, where it's exactly what you just said. The board is comprised of local bankers and political leaders and others from community organizations. And, these are getting into not only some unique arrangements, but that are still new. And as you guys talk about, emerging or evolving, even,
Right.
from deal to deal. So there's a lot of variation, and that can be kind of challenging and potentially risky, I guess, as well, which is interesting. And maybe Tom, I think it'd be interesting to get your perspective on this. But as you were talking, I started to wonder now, having represented a number of hospitals outside council, but now on the in-house side at SEL, I'm curious to kind of get your gauge on some of these newer future models. Where are we in this evolution, if you will? I mean, I know every conference I go to, every media publication I look at in the healthcare industry, seems like people are talking about telehealth. And of course, we've been talking about a lot of other technology related solutions and new models related to that over the past few years. But, what is your assessment on kind of where we are in that evolution, and as far as hospitals actually implementing successfully some of these new models?
Yeah, it's a great question. And, it really, answer is almost only to be given on a case by case basis, right? I mean, every relationship is different. Again, that goes to my comment previously. I think when affiliations, when there was a large wave of affiliations, and still to a great extent, there was, it's got to be one of three things. And if it's not those three things, then we're not interested on either side in some respects. But now, again, you see kind of these more custom type relationships. So you see large health systems and rural hospitals really kind of evaluating, well, what makes sense, right? Let's partner with each other, and let's see where we can leverage your resources and where they make the most sense, and then they will leverage a number of these types of different arrangements in trying to kind of customize what that relationship looks like. So as far as where we are in that evolution, in my mind, that shows maturity. It shows that, again, the arrangements that are put together tend to fit the needs of both the parties and really increase the chances of some of those affiliations working out more often than not. And I think that's held true with both what I've seen as an outside attorney and now as in-house counsel. And, maybe just speaking for a second as to the sophistication, technology certainly plays a big role in how some of these models have evolved in and of themselves. Obviously the EMR donation wasn't available until, just a few years ago. So just having that technology available for health systems to donate to smaller hospitals is a big win for both sides of the equation and for patients, really, because now they can get a shared record as between a large system and a small hospital if they're having to go back and forth between the two. And then I think some of the systems that have deployed that technology have become more sophisticated in how they support the service, how they implement it, because as we all know, EMRs can be a little bit tricky from time to time, even though the concept in and of itself may seem a little straightforward. And I'd say also on the telehealth, I think telehealth is one of the tools that we will see more and more, both in the rural and the urban setting, right? In the rural, it's more driven by necessity in the sense that, distance creates a need for an option whereby a provider can, provide some follow-up care or some initial care through telehealth where it makes sense, maybe because weather's bad on a certain day and they can't get out to the community, or the nature of the visit is pretty straightforward. So I think you will see the tools and the nature and the complexity of the arrangements continue to evolve there. But I think folks were a little bit more tepid in terms of how they approached those in the past, whereas they're getting more comfortable with it. And again, I just make the note even on the urban setting, and this plays out a little bit in the rural environment as well. Telehealth is a consumer-driven thing too. The younger generations want on-demand healthcare. They want it in a virtual form, and it's a whole separate conversation. But you see telehealth technology evolving to meet that need as well, and I think that the rural hospitals will benefit from that as well as the health systems deploy dual strategies to both meet the consumer needs and the needs of the rural affiliates.
Yeah. And can I just build on that from the association perspective? I completely agree with Tom that, we're going to see more and more telehealth as we move into the future because it provides a lot of benefits and solves many of the challenges that rural communities and other communities outside of rural areas are facing in terms of true access to primary care, to specialty care, and other healthcare services. But one of the things that we sort of weave into all of our advocacy efforts on behalf of rural hospitals and our hospitals in general is really that point that Tom made around flexibility, and we're not going to see things in just one way. We see hospitals doing a lot of creative and innovative things to maintain services in their communities. And as we advocate for new and emerging models into the future and the changes to regulations that are needed to support those models, we are taking a broad approach. We know that one size won't fit all. One solution may just work for one rural community, and we want to be able to provide a menu of options that they could select from. So we're working on a bunch of things related to telehealth. We're working on new models such as the 24/7 emergency department that would require a change in regulation to have that even be in play as a Medicare designated category. So we're also looking at ways to help hospitals address the social determinants and a variety of other things. The point being, if you've seen one rural hospital, you've seen one rural hospital, and there definitely needs to be a full set of service line of options available for hospitals around the country.
Yeah, I think that's a great point. And we always say, healthcare as an industry is always a local industry, right? It's a local business, and each community has different needs and dynamics. And I think when you look at that in the rural setting, especially, it's even a little bit more unique. And so that's probably an interesting, I don't know if challenge is the right word, but an interesting thing for the AHA to try to ultimately tackle, because I'm sure you guys are dealing with a wide range of pain points and issues and needs from your member hospitals, and trying to tackle that at a federal and then local level as well has to be pretty daunting task sometimes.
Sometimes it is, but we are usually pretty good at getting the right set of solutions out that can work for most of our hospital members, and this area of new models is just one example of how we do that.
Do you feel, Priya, that the alignment is that a high acuity issue for the hospitals that you're talking to? I mean, is that a major pain point, or is it something that is just kind of a dynamic that it's the new normal? They're all having to deal with, but they're able to kind of find that option that fits them best and pursue whatever makes the most sense for that particular region, organization, community, et cetera.
Yeah, I mean, I think we're definitely seeing hospitals have this conversation on a more frequent basis, and we're seeing that across the board, not just with rural hospitals. I think that there are so many challenges being placed on hospitals around the country. They're constantly asked to do more with less. They're facing higher input prices. They are treating more chronic conditions. There's just a variety of different things happening in the healthcare landscape that are forcing hospitals to figure out how they can do the best to provide services to their communities. And that involves having a lot of different conversations, and it includes the ones on the spectrum of what we've talked today about alignment. It also includes having conversations with non-traditional community stakeholders that may be partners now to help deliver transportation so that patients can actually get to their medical appointments, to help meet food needs of their community. There are just a lot of different conversations that are being had now at a more rapid pace than we've seen in the past.
Sure. Sure. Well, that's very helpful, and I guess getting us back to you all's presentation and bringing it full circle. Maybe Tom, if you don't mind, jump in briefly, and because I think we have to talk about, if we're talking about these models, particularly future models or evolving models, what are some of the legal and perhaps regulatory considerations that pop up as hospitals are considering these models, and what are some of the things they're going to have to confront as they work through that process?
Yeah, no, and I'll run through them just pretty quickly here, so that listeners have at least some heightened sensitivities to the area where you kind of do see on a regular basis some of the same laws implicated. But I spoke a little bit in the presentation, and what generally rears its head with a lot of these arrangements is the federal anti-kickback statute and any state law we call mini kickback statutes that may come into play depending on what state you're in. I'm trying to bring it to a higher level as strategy people get together, as business folks get together and look at these relationships. They obviously will speak to the benefits both for the community and the health system that such relationships can ultimately generate. And natural to that conversation is to think about the referrals that may be passed between the parties. And some of the listeners might be aware the kickback statute essentially prohibits a person from knowingly or willfully entering into an arrangement or offering remuneration or soliciting that remuneration in exchange for to influence referrals. I'm kind of just paraphrasing the law, but I think it's somewhat self-explanatory in that respect. And the nice thing about kickback is that it's an intent-based law, meaning that for the government to bring or to prosecute under that law, they need to show that intent was met and that a party to one of those arrangements was knowingly doing it to generate or to influence those referrals. But the other part of kickback is that all the government has to prove is that just one purpose of the arrangement was to do that. And so kind of trying to translate into the general practice in these conversations, as folks are structuring, as they're looking at the different options, it's important to understand that law will apply here, and there are various safe harbors that are available to insulate the parties from potential prosecution under that law, as it is a criminal statute. Priya mentioned this earlier. You're dealing with a lot of local and state laws too, because some of these are county hospitals, special districts, whatever you might call them, and so there might be some state laws that will uniquely govern those entities. So as you're structuring joint arrangements or other arrangements, be mindful of those and that they are structured to meet any kind of unique requirements that may be imposed on some of those entities. And it also brought the example of other state laws that might be implicated. For example, different states have different telehealth laws that will govern how providers performing telemedicine services need to be licensed and how they get informed consent, what drugs they can prescribe. So being mindful of some of those state and local requirements, again, that may govern some of the arrangements. So again, my sensitivity in some of these arrangements is normally with the kickback statute. I think that's kind of the bigger one, and any state law complement around, particularly as it might apply to the Medicaid program, and then considering those more discrete state law requirements depending on the arrangements. I think that's where the sensitivity should be from a legal standpoint with these relationships.
Sure, that makes sense. Yeah, I mean, I can imagine with each new model, or as the existing models evolve, compliance is always on the front burner as far as checking those things off the list or making sure fully up to speed. So I'm sure that's not going to change anytime soon. Well, this has been extremely helpful to go through and recap some of this. I guess as we kind of bring it full circle and close out, any kind of concluding thoughts or closing thoughts that you guys want to convey?
Yeah, this is Justin. I'll just make a couple, and Tom and Priya feel free to add to it. But as Priya highlighted, I think there's so many reasons why rural hospitals are looking towards larger health systems or other partners for alignment opportunities to try to provide some relief and continue to provide that much needed service to their local community. As we also talked about, there's so many options, and what we focus on is substance over form, meaning what are the key needs of the community and what alignment models meet those needs. It doesn't always have to be some of those massive foundational models. It can be something small that meets an acute need, and that plays into the idea that we can start small and build from there, meaning we don't have to go to the big bang at first. We can start with visiting specialist or some kind of joint venture or service line. And then if those are successful, look beyond that to something else. And then, as Tom articulated, as with everything in healthcare, there are nuances, especially legal nuances. And so consulting with appropriate healthcare legal counsel is always a must as we get into these initiatives.
Yeah, and I just like to add, I think the one thing that struck me from our conversation at the meeting was the need for the conversation. I did have several people come up to me after and say, this was really great. We need to have these conversations around alignment. I have several rural hospital clients that are looking at these issues now. And I think that it's important that we continue to have this dialogue and we talk about the range of options that are available and how our rural hospitals can form the right legal arrangements and legal relationships to make these happen so that they can continue being, a key access point to healthcare in their communities.
Yeah, and I would add, and I think those are all great comments, Justin and Priya. Priya gave a lot of great context around rural hospitals, and one thing I think is important, and I've come to appreciate working in markets, where there are a lot of rural hospitals, is the role they play, right? They are beyond just providing care. They are a major employer. In some cases, they are a symbol of pride for a small community, and so their preservation, not only in that respect, but again in being a community asset. Whereas in an urban area, you might take for granted that you have 6 different hospital systems that offer redundant programs. Again, in the rural areas, I think they may appreciate the care that's local more so than in the urban area. And so I kind of to echo something that Priya said, there's a lots of options available. There's not a one size fits all, take it or leave it type of alignment model. And I do think this is a very appropriate conversation as to, well, how do we do it and what are the other options kind of in between? And I think as folks entertain that, I do think they will lead to more beneficial partnerships and more successful partnerships. And then as the attorney, I'll always plug for, as we put together all these great ideas and these arrangements, that it's obviously important to tease out the legal nuance and make sure that they're structured appropriately, because we all know that the healthcare legal and regulatory landscape is a tricky one.
Yeah, well, very well said. And I think, to Priya's point, this is something that we're going to continue talking about more and investigate further and continue to monitor as these and other models continue to emerge and evolve. So it's I know is a hot topic for the conference, and I know this will be helpful to have as a recap. And again, we'll make sure all of you all's information is available in the show notes so that people can contact you guys, further questions or follow-up material. And then we'll hopefully look forward to talking about it again in the future. So thank you for joining us.
Thanks so much.
Thank you.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.